Welcome to the Headache, Migraine, and Chronic Pain webinar. We're glad you're here with us today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is co-sponsored by ourselves, CIRPD, and Pain BC in collaboration with the Canadian Pain Coalition. This webinar has been made possible through the support of the Community Gaming Grant programs through the BC government, as well as through donations and memberships to our organization. As I mentioned, my name is Tanya, and I'm moderating the webinar and handling the Q&A session today. And our presenter is Dr. Gordon Robinson. Dr. Robinson is a clinical professor and director of undergraduate education in the Division of Neurology at the University of British Columbia. He's on staff at Vancouver General Hospital, where he's the medical manager of neurology. For over 20 years, his practice has consisted of the assessment and management of headache disorders. He has been involved in providing headache education to the public, physicians, and other health professionals. Dr. Robinson is a member of the Canadian Headache Society, American Headache Society, and the International Headache Society. Thank you so much for being here with us today, Dr. Robinson, and for forging through some of the technical difficulties. I really appreciate it. I'll hand it over to you now.
Thank you, Tanya. No, you're quite welcome. I'm quite happy to do this. The title is a bit misleading in a way because I'm not going to be able to talk about all the things in the title. I'm really going to focus in on chronic migraine as a specific entity, which is probably more of interest to people that are dealing with chronic pain disorders. Disclosure side, advisory board, Allergan, which is about it. So the burden of illness, demographics of chronic migraine, management, and hopefully get into not just current treatments for chronic migraine, but also some exciting developments that will be coming in the not too distant future. First off, an overview of how headache is approached as an entity. Virtually all headaches are diagnosed by history. Very few of the headaches have what one would call objective measures, such as scan abnormalities. So in a headache practice such as mine, which is basically an office practice, all the time is taken is on history. And headaches are divided into two large groups: primary headaches, and secondary headaches. Secondary, obviously from a definable cause. Common ones that I see would be post-traumatic headache. Others are more emergency driven. You see a lot of people with CNS infection, meningitis, vascular disease, stroke, intracranial hypertension, subarachnoid hemorrhage. And these are obviously secondary headaches and diagnosed based on the entities themselves, and headache just happens to be part of their symptomatology. The major primary headaches are migraine, tension-type headache, and the trigeminal autonomic cephalgias, and the preeminent one in that group is cluster headache. But again, we're really focusing in on migraine because it's beyond the scope of a webinar of this duration to cover the whole field of headache. So migraine in the most recent classification is defined as three major entities. And certainly in population-based studies, migraine without aura is the most common. Upwards to 15 to 20% of most populations surveyed in the general group suffer from that. Migraine with aura, the patients who have migraine headache, but it's preceded by usually visual symptoms that are reversible, are in the minority, but those are the biggest two. But a sizable number of people do suffer from chronic migraine, which, although it's been around for generations, obviously, it's only quite recent that it's been included in the classification, only quite recent that it's been measured in any way in the population, and treatments are slowly beginning to be rolled out in managing what has been historically one of the migraine disorders with the highest morbidity and the most difficulty when it comes to managing in a practice. So when we think about migraine, you can think about it as a spectrum of severity in a way, or a spectrum of morbidity. The lucky folks in our population are at the left side of this slide, in that they don't get headache, they don't get migraine. It's pretty rare to see someone that never gets anything at all. Most people do get occasional mild headaches, which I would argue are mild migraine, but they basically aren't headache sufferers. The majority of the people that do have migraine have low frequency migraine, on average once a month. Some people a bit more, other people less than that. And then it moves on into high frequency migraine, which would be at least one a week, and that's 10% of the total migraine group. And then the entity that I'm talking about mainly in this session, which is chronic migraine. And these people have a huge burden of migraine, often constant headache, and multiple episodes of moderate to severe migraine on a weekly basis. And this, you can move along this spectrum through your headache career, starting at no migraine, moving into low frequency. Most people, fortunately, stay in that group. But then people transform into higher frequency and chronic migraine, and then either spontaneously or through successful treatment approaches get moved back across into a more controllable disorder. Everyone dreams of going back into non-migraine. I wish I could say that we had a high degree of success for doing that, but we're getting better and better at moving people to the left of this spectrum from the large numbers that we see in the chronic migraine group. And this is referred to as transformation, basically going from left to right in that slide as a progression. How many people out there have this? Well, in a population in Canada, and this is extrapolated from the United States, around 2% of the population has chronic migraine as defined by the criteria, which is quite a big group. In a specialty headache practice, probably approaching 60 to 80%, I think 30% is kind of low, of patients have chronic daily headache, and the vast majority of those are going to be chronic migraine sufferers. What is it? Well, first off, it's a chronic headache syndrome. So it's going to be present for at least 3 months. For most people that we see, it's been present for years. By definition, they are going to have headache on 15 or more days per month. Many people I see have headache 24/7, 30 days a month, and every waking hour they're aware of some measure of head pain. And they meet criteria for migraine for their more severe headaches on at least 8 occasions throughout the month. And that means that headaches may be one-sided, they're throbbing in quality, they're at least moderate, if not incapacitating in severity. Their headaches are aggravated by physical activity. Those are the 4 major characteristics that we use in diagnosing a migraine attack. And then the associated features of stomach upset, even to the point of vomiting, and sensitivity to light and sound. So you've got this background of a more or less continuous low-level headache, and then at least 8 times a month, they have headaches that get more severe and meet criteria for migraine as a disorder. And it exists in more or less 2 forms, either with or without medication overuse. And this is related to the knowledge that came about 30 or 40 years ago that in people with migraine, for some of them, as they used more potent and more frequent medications, usually analgesics containing codeine and caffeine, but originally reported with ergotamine and then later with the triptan drugs that were released in the 90s. As they used these more and more, a subgroup finds that their headaches get more frequent and more difficult to control until they end up qualifying for this diagnosis of chronic migraine. And if they're using these medications on the majority of days, criteria about more than 12 days a month, then they're considered to probably have chronic migraine with medication overuse. And then there's the other group that aren't using medication nearly to that level, and they have chronic migraine without medication overuse. Who are they? Well, vast majority are women, approaching 80%. This takes time to evolve, although we do see it in all age groups. Certainly it's seen in adolescents, but the peak prevalence is in 40s, with a history of a gradual transformation from low frequency to high frequency to chronic migraine, taking 5 to 10 years from the outset of their headaches, which may have occurred in teens or 20s. Associated comorbidities include obesity. One could also put sleep disorder in there. And then the psychiatric comorbidities of depression and anxiety, and an overrepresentation of some other pain disorders, fibromyalgia, and also irritable bowel syndrome, all adding up to a pretty high level of morbidity for this disorder, particularly if you have these associated features, which are actually quite common in this group of headache patients. We look at why this happens, why someone would move from a lower frequency to a higher frequency of migraine into chronic migraine. And there's things that we really can't do anything about. Age appears to be a factor. As migraine patients go into 40s, particularly women, they have an increased risk of this progression. And again, females more than males. In the U.S. studies, low education, low socioeconomic status was correlated with this. And then the group of patients that have a superimposed head or neck injury, a background history of migraine, head or neck injury that may or not be that severe, and from that time forward, their migraine becomes much more frequent and severe and qualifies for the diagnosis of chronic migraine. And those things we can't really do a whole lot about. The ones who think that we can improve would be to treat the low to moderate frequency migraine patients as effectively as possible to see if this would prevent that progression. Obesity, I suppose, is treatable, but that's not in my area, and certainly is a struggle for the vast majority of people who have it. The medication overuse is a big modifiable factor. Not getting there in the first place by educating patients not to use their symptomatic medications more than 3 times a week on a concurrent basis. Stressful life events, handling those properly. Caffeine overuse really feeds into medication overuse. Snoring is, code for sleep apnea, which can be something that can aggravate migraine and end up being a risk factor itself, and perhaps preventing other pain syndromes that may be a factor in causing migraine progression. There's a number of investigational approaches that are being looked at. Allodynia is a phenomenon that's quite common in the migraine population. This is a fancy word for a normally non-painful stimulus hurts. So in the midst of migraine and even all the time in many patients with chronic migraine, a light touch to the scalp or even just movement of the hair is painful. There are pro-inflammatory states that are being measured, pro-thrombotic states. These are really quite investigational and may or may not be important. And then at the basis of everything in migraine is the genetic predisposition. And it's not fully unraveled at this point, but are there specific genes that cause us to suffer from migraine? And is there a genetic makeup that actually pre-programs certain patients to transform either early or later, no matter what happens in their life, to a chronic migraine disorder? Medication overuse is a huge topic in the chronic migraine group because it tends to be present in at least 50% of those patients. And as I mentioned earlier, it may lead to transformation as a form of headache, medication overuse headache. We see many people who aren't overusing, so it's obviously not the whole story. And the treatment is pretty obvious. One has to extricate these people from their symptomatic medications, use the other treatment modalities, both pharmacological and non-pharmacological, to try and get them back into a better controlled, lower frequency migraine state. There's many people who do not overuse medication, and there is also a large number of patients, somewhat disappointingly, who sound and look like they have medication overuse headache. However, when the medications are withdrawn, even over a period of months, their headaches really don't get better. And is this because there are factors that we don't know of driving the headache? Or, and this is a bit of a scary one, there's some research that suggests that if you transform from episodic migraine to chronic migraine from overuse of medication, irreversible changes occur within brain, so that even though the inciting factor, the medications, are withdrawn, you're stuck. You're now in a higher frequency migraine disorder. And as yet, we don't know the answer to those two as to whether that makes it even more important to not get into an overuse situation very early on in the management of patients with migraine. What do we know about migraine itself? Well, it's a disorder of brain. We know that at the beginning of a migraine attack, there are cortical reactions that become disinhibited, and there's a release of active substances across the surface lining of the brain, stimulating trigeminal sensory nerves over the meningeal surface that communicate through the skull, in fact, so that you end up with an actual headache disorder. The major release factors are neuropeptides, and the one that's becoming increasingly interesting is CGRP, calcitonin gene-related peptide, and I'll talk about this a bit later on when it comes to treatment opportunity. We know that the same trigeminal nerve that becomes activated reports the pain stimulus back to the first relay station in the brainstem, the trigeminal nucleus caudalis. And if this goes on long enough, the whole thing becomes hypersensitive, and this results in a phenomenon referred to as central sensitization. And everything becomes activated in pain centers. When this occurs episodically, you have an attack of migraine. When this system more or less gets stuck on, then you've got a chronic migraine disorder. So we think of episodic migraine as intermittent central sensitization, and this is brain generated through the trigeminal system with the blood vessel as the target organ. And we tend to think of chronic migraine as a constant, persistent sense of central sensitization, as if the migraine is stuck on, and our management is doing an attempt to reduce that and get it back to more of an episodic disorder in the spectrum of migraine difficulties. So how to do that? Well, it's easier to talk about than to do. It can be a pretty complex picture, seeing some of these patients who have severe, unrelenting migraine disorders, who have a lot of comorbidities, and it's best handled in a multifaceted approach, probably best handled even in a headache disorders clinic, where you have not just the physician-based model, but other practitioners in different disciplines who can help these patients control their headache disorders better. Lifestyle modifications, behavioral therapy, big for many patients. Education is huge, getting people to understand their disorder, managing expectations, being able to see them regularly is a very big part of the successful management. And there's a lot of pharmacological therapy that goes on in chronic migraine. Not much research to date supporting that, but it's coming, and the future is looking somewhat more optimistic in the management of chronic migraine than it was 5 or 10 years ago. Medication overuse, the cornerstones: drug withdrawal, breaking headache cycle, behavioral modification. Many patients over the years become extremely fearful of their migraine attacks, and they medicate almost preemptively. Like, I'm going out for dinner tonight, I don't want to get a migraine either before or while I'm going. I think I'll take my symptomatic medication now rather than wait. And it becomes something that they do on an ongoing basis, increasing the risk of frequent medication use into an overuse transformational disorder. So they need an acute treatment plan that will not do that, with very clearly delineated limits. Prophylaxis, both drug and non-drug, is important, and follow-up is a big deal. You can't just do these things and then just send people off to their own devices. Relapse rates are extremely high unless follow-up is meticulous. The non-pharmacological treatments, certainly very important. Overall general health, education over the disorder, medication overuse I've talked about repetitively because it is a major phenomena in chronic migraine. There's some evidence that quitting smoking improves migraine. It's not the strongest evidence in the world, but use whatever you can when it gets to getting people off cigarettes. Sleep is a big deal. Eating patterns, worsening obesity is not a good idea. It'd be better to try and go for the weight loss. Exercise. Biofeedback and behavioral treatments have been extensively studied in episodic migraine. Some studies in chronic migraine showing efficacy, cognitive behavioral therapy, and then the things that we do with all headache patients: identification and avoidance of triggers, and headache diaries, monitoring the disorder, and also the medication usage. And so these are all the building blocks of non-pharmacological treatment that are employed for patients with chronic migraine. Medications have been increasingly important in migraine, certainly since the introduction of the triptan drugs in the early 90s. Trials of medication in chronic migraine, preventative medications, are not that extensive. I've highlighted here the two that have been the best studied, Topiramate and onabotulinum toxin A. Topiramate's original brand name was Topimax, and onabotulinum toxin A is Botox. And these are the newer studied pharmacological treatments for chronic migraine. There are other drugs that have been looked at, but not nearly as extensively. Trials are really quite small. And some of the mainstays in treating episodic migraine preventatively, such as beta blockers and calcium channel blockers, they have had small trials or not been looked at in any way. So the evidence base mainly lies with Topiramate and onabotulinum toxin A. Topiramate was studied some time ago in the treatment of chronic migraine. It's been well established to be an effective preventing agent in episodic migraine. And this was a trial that was done in the United States, and there was a modest reduction in migraine days in the treatment group compared to the placebo group. Adverse events were difficult. Many people get numbness and tingling, face, hands, and feet. It's not usually that disabling. If you increase dietary potassium, it's often reduced, and not that many people find it disconcerting enough that they're going to stop the medication. The problems that are encountered with Topiramate tend to be the cognitive inefficiency, concentration, attention, difficulty with memory, and the more specific complaint that patients come up with if they do develop this with Topiramate is word finding difficulty, and their speech slows and becomes scanning, and it's both frustrating for the patient and in many ways more frustrating for those around them. So it is a daily drug, and although it can be efficacious in patients with chronic migraine, side effects can be limiting for many people, but not all. Some people do extremely well using Topiramate daily with a target dose of about 100 milligrams in the treatment of chronic migraine. Botulinum toxin A has also been studied and is in considerable use in the treatment of chronic migraine. And this has an interesting story of development. Botox was initially introduced, certainly in the Canadian market, in the late 80s for the treatment of spasmodic torticollis, and there have been other indications since that time. It was then pioneered for the use of hyperfunctional facial lines, which most of us would refer to as wrinkles, that occur with normal aging. And these are hyperactive facial muscles. And it was discovered that if you used Botox judiciously in those regions, that you would get really quite a good cosmetic result in many patients. And the cosmetic use of Botox has been going on for in excess of 20 years. And it was these patients who made the chance observation that the neurotoxin reduced headache. Many of the patients treated cosmetically were women. The prevalence of migraine in women in their 40s, early 50s is 30% or more. And so the protocol, putting it into brow and forehead, gave a positive outcome for many of these patients. And this drug had a reverse development in a way. It went into widespread use for the treatment of chronic migraine before the pivotal clinical trials that were reported in 2010. The positive clinical trial allowed it to be approved by the regulatory bodies, namely Health Canada and the FDA in the United States, and it's now approved worldwide for the treatment of chronic migraine. The injection pattern, people always ask that question, and this is taken out of the what is called the preempt protocol, which was the acronym for the reported trial. And these are 5-unit injections, and so there is brow, upper forehead, temples, occipital region, suboccipital region, skip the paracervical to avoid neck muscle weakness, and then upper trapezius muscle injections. So this was designed to cover all of the trigeminal and upper cervical regions with neurotoxin, but to minimize a cosmetic change and to minimize the risk of neck muscle weakness, which are the only two potential side effects of having neurotoxin therapy for chronic migraine. Well, the third one is disappointment if it doesn't work, but it's a incredibly safe treatment, and the side effects, if you want to call them that, neck muscle weakness and the brow changes that are undesirable, are easily fixed by dosage modification and placement modification in the injected protocol. So we're really not dealing with side effects in these patients. It really is all about whether they get efficacy or not when it's used. The clinical trial was somewhat underwhelming when it came to how well patients did. Clinical practice is, in fact, more dramatic, with many people having quite miraculous responses, although not everybody. In the trial, 70% of people were eventual responders. And this slide and the portion that I highlighted is oft quoted, showing the reduction in headache hours over that month. So it's almost 40 headache hours compared to the placebo control group, and it was enough to give it a positive rating with the regulatory body. But as I say, I find this overwhelming and really doesn't quite compare to what I see on a day-to-day basis in patients who do respond to neurotoxin therapy. They get a much more robust reduction than this. Another way of looking at it is to look at headache hours, and the orange is the active treatment group during the double-blind phase. And you can see that as it went on, there was an increasing split between those patients and the placebo group. And then the open-label phase, where everybody got neurotoxin, the placebo control group did better and better. One of the other things to gain from this slide is something that we've discovered, that not everybody responds the first time. And when the trial data was analyzed for that, a sizable number of people didn't respond well until after the second treatment. It was nearly 25% of the eventual responders, and about 10 to 15% of people needed 3 treatments. So the current approach is to tell people that if you're going to try this, hopefully you can commit to 3 consecutive treatments before you can fully judge efficacy. And consecutive is important, 12 weeks apart, not a treatment in 2012 and another treatment in 2014 to judge efficacy. The consecutive nature appears to be a needed part of the treatment trial. The treatment-related adverse events, this is in the trial where nearly 9% of people had neck pain, the muscular weakness, lesser, headache. Well, they all have headache to start with, so there's a bit of a mislabel to this, I find, that some people feel that their headaches are worse afterward. That may be true in a small number, but most times when you look at it critically, the headaches are worse because it takes a week or two for the neurotoxin to become active in reducing the headaches. So it's a kind of a more apparent than real worsening. It's worsening because they're not treated in essence for a week or two, rather than any reactive thing to the neurotoxin. That's my opinion. And the numbers are in practice, when you get adept at using it, are probably lower than this. I would think that neck muscle weakness and neck pain are single digit, probably 2 or 3% at the most. And the other phenomena is something called spocking, where you get one eyebrow or both eyebrows going up more in the middle and outer third rather than symmetrically, looking like Dr. Spock from Star Trek. But again, that's easily fixed and is temporary. No one's yet died from that one. Why does it work? Well, it's kind of interesting showing this because it underscores what we think chronic migraine is. And in this slide, this is a rat formalin pain model, and a rat's hind paw is injected with formalin, which is extraordinarily painful apparently. And when the animal is observed, they have a 2-phase pain response. First off, the phase 1, where there's a lot of motor activity with the initial pain response, and then it tends to settle down for a period of time, and then you get a building second phase response, which is thought to be due to sensitization of the sensory nerves as a reaction to the formalin. And as the animal was treated with increasing doses of neurotoxin, it was the second phase that was predominantly suppressed. And the bottom yellow triangles show almost a completely non-existent second phase in the pain response, indicating that this prevents secondary sensitization. And it's thought to be sensitization, as I outlined in the previous slides on the background of what chronic migraine is, that is the target for this particular treatment. Injecting it into scalp allows it actually to affect the trigeminal afferents. New neuroanatomy has shown that these actually go through the skull itself, so that injections of neurotoxin outside the skull can actually be taken up by the trigeminal sensory neurons, not just in the scalp, but getting into those that are important over surface lining of brain to suppress the phenomena of peripheral sensitization. So inhibitor of inflammatory neurotransmitters inhibits peripheral sensitization, and when it works really well, it turns that light off. and patients have far fewer migraine attacks. Some evolving therapies that could be of interest to you. Neurostimulation is getting an increasing look at it. Occipital nerve stimulation has actually been around for some time, and there have been trials of it. And this involves implanting a strip of stimulating electrodes across the back of the head in the suboccipital region. Some patients will also have stimulating electrodes put into temple and even into forehead if that's necessary in trying to control their unrelenting headache. It usually starts with the occipital nerve stimulation. And then somewhat newer non-invasive vagal nerve stimulation is being trialed in chronic migraine. The study on the occipital nerve stimulation did show some decent results in the active pain group. This is at 12 weeks after the stimulator is put in. And you can see in the active group, which is in the darker bars, their pain relief, excellent, good, fair is much higher than the placebo group. And the problem is actually trying to figure out who's a good candidate, who isn't. And also, since this study, it's been shown that stimulation may have to go on for months before people eventually respond. It's not something you implant and turn on and you get your relief right away. MIDAS is a well-validated quality of life scale used in migraine, and this shows a reduction in the scores in the active group, indicating that their migraine, chronic migraine, is better controlled and their quality of life has improved over the placebo group. Calcitonin gene-related peptide, if you remember earlier, that was the neurotransmitter that I mentioned when we were talking about the pathophysiology of migraine. And this has become an important target for treatment, being looked at in two ways: small molecule antagonists of CGRP, and then monoclonal antibodies directed against CGRP. It's an important neurotransmitter, and this has been known for some years now, that it's released, it goes way up in migraine attacks and also in cluster headache attacks. If you infuse CGRP into migraine patients and cluster patients, it will trigger an attack. It goes to baseline if people respond to triptan medications like sumatriptan. And it's in sites in the brain that we think are important in the development of migraine. The trigeminal nucleus canalis, the periaqueductal gray thalamus are rich in CGRP and therefore potential targets. The small molecule treatments appeared to be relatively good for migraine attacks. Unfortunately, when they were studied on a prolonged basis, there was potential liver toxicity. And so the small molecule antagonists have been abandoned in the development stage, and it seems that they're not going to see the light of day when it comes to the treatment of episodic migraine. So attention has turned to monoclonal antibodies, which are highly desirable treatment options once produced, and if effective, they are long-lasting. Their tolerability is incredibly good, and they could possibly be the magic bullet when it comes to controlling migraine as a disorder. These are phase 2 results. There are 4 of these monoclonal antibodies in development, and this was the one that's being looked at as a monthly intravenous infusion by Alder pharmaceutical company. And really interesting, the active group that received the monoclonal antibody had a significantly improved response at 50%, 75%, and 16% of patients who received it were headache-free during the time that it was active. So all of these drugs are now reporting their phase 2 results, which appear to be promising, and they are all entering phase 3. And if that pans out, probably within the next 2 to 3 years or so, we may have an extremely interesting biological treatment for chronic migraine and also high-frequency migraine based on blocking, if you will, CGRP at all of these sites. There have been no significant toxicities or adverse events reported in the phase 2 trials, and phase 3 is soon to get underway throughout the world. So that makes it through a presentation on chronic migraine, and I'll be happy to answer any questions at this time.
Wonderful. Thank you very much, Dr. Robinson. That was a really great presentation. We do have a few questions. There were 2 questions around kind of the, I guess, not triggers, but kind of side effects of migraines around light and hormonal changes in menopause. I'm wondering if you could talk about those 2 items a little bit more.
Well, part of the diagnosis of a migraine attack is the presence of sensitivity to environmental stimuli, commonly light and sound. People can also be smell sensitive during a moderate to severe migraine attack. It's not, absolute that you have to have that, but the vast majority of people that have a moderately severe migraine, either those that have episodic migraine or chronic migraine, will be light and sound sensitive. It's part of the disorder, just as stomach upset is part of the disorder. And one of the reasons that migraine is not just a headache, it's a much more global experience for patients when you have also the non-headache symptoms being present to a large degree. The question on hormones, that could be an hour in itself. I don't think anyone doubts that the underpinning of why migraine is more frequent and prevalent in females is really all about hormones. And for decades now, it's been thought to be primarily related to estrogen. Up until menarche, boys and girls have about an equal frequency of migraine. From menarche on up into the 50s and perimenopause, the prevalence of migraine becomes higher and higher in women, but not men. The premenopausal decade is often the worst. The menopausal decades are what a lot of people with migraine are hoping and praying for. Most get much better, even to the point of complete remission. It's not 100%, unfortunately, but the majority of people, particularly those who have their migraine in and around menstrual periods, who have had complete or considerable relief during pregnancies, those patients often enjoy remission of migraine in menopausal years.
Very interesting. All right. And then someone had a question. Do you consider days following migraines where you're still having partial migraine symptoms to be migraine days? And I think they're talking specifically in journaling and trying to assess for speaking with their physicians about it.
Well, that's called the migraine prodrome. In a patient with episodic migraine, it will usually last hours to a day and be moderate to severe. The day after, it's usually not longer than a day, but for some people it could be a bit longer. It's often referred to as feeling like they're hungover. They've got a bit of a dull headache. It's not bad enough to stop them from doing anything. If they bend, if they exert themselves, shake their head, the headache will go up for a little bit. It wouldn't be called a migraine day in a headache calendar assessing for chronic migraine. It would be a headache day, But the headaches wouldn't meet criteria for migraine based on the associated features and the severity. But migraine usually doesn't just turn off like a switch. After you've had a pretty substantial migraine for hours to a day, there is this gradual improvement before everything goes back to normal for hours into the next day. Usually by the next afternoon and evening, people are again feeling back to their normal.
All right. And then if the migraines came after a head injury, when would migraines normally develop? Would it be a matter of days, weeks, months?
It's usually quite close to the actual injury. It's head and neck injury, and most of the patients that we see, it seems to be related to the neck injury. Certainly in the rear end collision whiplash group, that is the primary injury. Virtually every other head injury comes with a neck injury. You can't escape it because your head is sitting on top of your neck. And the headaches will usually begin that day or within days to a couple of weeks. In the classification, they have arbitrarily put 7 days after head or neck injury. But again, that's arbitrary. It's not validated. It's just a place to start. Most of the people I see will have their headaches established within days of such a trauma. And the longer out before headaches become a substantial issue, the lesser chance that they are trauma-related. But there's been many cases reported that weeks or even a few months go by before headaches begin. In my experience, that's usually related to additional factors, increasing mood disorder, post-traumatic stress disorder, depression, difficulties with sleep. So you get this delayed phenomena where there may not be that much headache at first, but when those things become more active weeks or a month or two later, what was previously a mild headache disorder becomes substantial, and people then begin complaining of it as a more severe part of their syndrome.
All right, and then we had a question about the Botox treatment. Wondering if someone, essentially, how many treatments before someone might decide that it's not helpful any longer? Is there kind of a general estimate?
Yeah, the consensus at present would be 3 consecutive treatments. After you've done that, with it being done at the dose and pattern and based on the preempt protocol, what you're going to get into the future beyond that 3rd treatment is what you're going to have. And if you've had no response, then I personally don't think there's any reason to carry on hoping it's going to work the 4th, 5th, or 6th time, because it won't. And it's a matter of how well you've done. If it's substantial, then it's an easy decision. There's that borderline group who maybe they're a bit better, maybe they're not, and that's a personal decision. But 0 for 3 is pretty well it when done consecutively, properly in a chronic migraine patient.
All right, and then we have a few questions from people who work kind of in the return to work and assisting people getting back to work, and saying that with migraine, there's a lot of complications, and wondering if you are aware of any research in that field, and if you could talk about it even just a little bit about some of those tactics for assisting those people.
Well, I'm not aware of any research specifically looking at the return to work side of things. That we cannot cure migraine. We attempt to control it as much as possible. And if it's out of control to the point that the person is off work, then that's a major treatment challenge. And whether or not you're trying to get them back to work, which in that case you would be, everything you do is the same. One of the bigger issues that I find difficult to struggle with is returning someone to work who's off because of migraine is more complicated than other disabilities, if you will. You once you start gradually recovering from trauma or other medical illnesses, it's kind of a a bit of a straight line, better and better and better. And you can easily design gradual return to work, so many hours a day, so many days a week, and escalating it. The problem with migraine is the damn thing's so unpredictable. You don't know if you're going to have a severe migraine on Wednesday or Monday of the coming week. And so fitting into a regimented gradual return to work is extremely difficult for many patients. And it ideally, it has to be more customized. I mean, the patients that do the best, have flexible hours, and they can work when they can and work when they can't, but that's not going to work out for all occupations. So, I mean, I think that's the biggest difficulty, trying to fit people into regimented return to work programs in a disorder that has the unpredictability of migraine.
Very good. And then there's a question around if you know of any evidence of daily mindfulness meditation helping with migraines?
Yes, there's been biobehavioral studies going back decades in episodic migraine. Relaxation training of various types, that would be one of them. Cognitive behavioral therapy, biofeedback, have all shown reductions in migraine frequency and severity in about 40–50% of people who have access to those approaches and who are willing to pursue them and practice them on an ongoing basis. Probably underutilized for various reasons, but definitely have been shown to be effective as biobehavioral approaches for migraine for quite a long time now.
All right, and then with the Botox, there have been quite a few questions about that. If you get the Botox more than 3 times, how is that then continued to be effective ongoing? I mean, are you expected to then keep going if it is still working, and how long is that to be sustained?
Sure. Well, again, it doesn't cure anything, and so migraine is a chronic disorder. If you do respond within the 3 consecutive treatments, and say you respond really well, in my experience, you will continue to respond indefinitely. And how long you use it is depending on the natural history of your migraine. Perhaps if you're lucky, you have a component of medication overuse headache. You respond to Botox, which allows you to greatly throttle back your symptomatic medication. So you may have a chance of actually getting much better and not requiring Botox ongoing. But for the majority of people, as they approach the 3 months, their headaches will gradually begin to come back. They'll start waking up with a bit of a headache. They have the odd migraine attack, and then they're retreated and control is regained. And again, it's control. It's a suppressive therapy. It's completely reversible. And so people with a migraine disorder, which is chronic, to continue to have control using neurotoxin, it's going to have to be repeated. Fortunately, there are absolutely no long-term effects of it, and it's now been studied for decades. So it's probably the safest treatment one could offer, and it's excellent when people do respond.
Wonderful. We're running a little bit short on time, but the one last piece I wanted to have you speak about is for people who are looking to get treatment and wondering, are family physicians being educated about these things, and what kinds of clinics are available for people to go to?
Yeah, family physicians are being educated, probably not enough education as one would like. Certainly the medical school needs to step up and have more in sort of family practice residencies. Family doctors should be able to handle simpler migraine problems, but quite often they require specialist intervention, and most neurologists are knowledgeable. There are a small number of neurologists and some non-neurologists across Canada who are headache specialists, scattered in major cities in different provinces. As far as full-fledged headache clinics, the only one we have that comes close to that is at Foothills in Calgary. And then there's a headache clinic in Montreal that also has quite a few modalities. So those two centers, Calgary and Montreal, are pretty well serviced, although wait lists, because there's so many migraine patients and so few resources, are really quite long. Otherwise, it's either a neurologist with an interest or a neurologist who has actually developed a headache practice. Again, unfortunately, major centers across Canada rather than everywhere.
All right, very good. And then I think I'm going to go ahead and end because our time is come to a close. But I do have a few questions that we didn't get to for answering. Would you mind if I emailed those and then we can provide the answers for people afterwards?
Sure, that would be fine.
Wonderful. Thank you very much. And thank you so much for the presentation. I think it was very informative, and it's great to see that there's new progress being made on this front for the people who need it quite desperately. So
thank you. I'm happy to do it.